Hi guys, welcome to another episode of Protrusive Dental Podcast. This one's all about respiratory protective equipment. It's a massive topic at the moment, and I just wanted to help out by covering a little bit, mostly because I felt as though I knew nothing, and I had some people reach out to me, what do we do about our beards? Do we need to get FFP2s fit tested? This would make a good topic for your podcast. So I reached out to some guys. It culminated in this episode, which is going to cover all the very basics to the more sort of political, ethical questions around RPE in dentistry for whenever it is that we'll be getting back to work. I know the UDCs are working under some conditions whereby they have access to some forms of RPE. So we'll be discussing all that. I have to give a disclaimer that one of the reasons I made this episode was because I am concerned as a Sikh man with a turban and a beard about how I'm going to go back to work, and certainly for those in my community, how are we going to get back to work? And I want the voice of our community to be heard. So that's one of the reasons, but that makes up around about 0.2% of this podcast. This podcast episode is applicable to everyone, but I do want to reach out to my community and sort of offer them something. And basically, there's not much in it in terms of how I can help people with beards, Muslims, Jews, Sikhs, those of us who have facial hair. Essentially, we are at the mercy of the higher powers, the WHO, Public Health England, the CDO, NHS England. So all these bodies are advising us, and actually they are all blind. And what I mean by that is that there is just not enough evidence yet. So I think the method that everyone is now adopting is it's better safe than sorry. Hence why at the moment the guidance suggests that you should be using a filtering facepiece for any AGP related procedures. So that's where that guidance comes from. It may be that just a surgical mask and a visor is just as good, but the thing is we don't know yet. And I think due to political reasons and due to safety first and being it's better to be safe than sorry, that's the reason that we're going a bit extreme into some of the guidance recommendations in terms of the need to wear these FFP2 or FFP3 masks. So I think that's where that comes from. And the only thing I can say is that I was surprised to learn a little bit that all this RPE that we wear is actually mostly to do with protecting us, not so much the patient. Yes, the patient's important as a byproduct. The patient should be protected, but we'll also think about how to protect us. And it's interesting that, for example, if I was to wear an FFP2 mask with my beard, technically, I wouldn't even get certified to wear it because one of the guidelines is that you should be clean shaven. So we know that the seal actually degrades, and you can't be certain that every time you do a fit check that you've got a perfect seal. So for that reason, we think that yes, the dentist is not protected, but actually the patient maybe, we just don't know. Because the dentist can still exhale, and we don't know how much of that exhalation can affect the patient. We don't know how much of the viral load is carried in exhalation yet. We just don't know the answer. And of course, the majority of the masks that are available, or RPE that is available in UDCs due to political reasons and supply reasons, actually have an exhalation valve. So the exhalation air is actually coming out anyway. So to me, that seems no different to me wearing an FFP3 and knowing that I don't have 100% seal. So I don't really see that being any different. So there are lots of unanswered questions for people with beards and stuff. So that's the best I can offer. We really need a solution that's not going to depend on hoods because they're so cumbersome. But anyway, we cover all that and much more. Like I said, the beard thing is only a small part of this podcast. I really hope this helps everyone to understand about fit testing, fit checking, which mask do we need, why, is it a legal requirement to wear these masks, who's protected, who's not, how much do these cost, is it better to just buy a reusable one than a disposable one? So all these things we covered. I genuinely hope that you find this useful. Thanks so much for tuning in.
That's number one. Number two, we don't know. There's a lack of evidence, or there's no evidence on aerosols and risk of transmission. So we don't know. So there may be the fact that we'll get more evidence. There's maybe we will get different respirators that will come onto the market, and maybe we don't need them.
Welcome to the Protrusive Dental Podcast, the forward-thinking podcast for dental professionals. Join us as we discuss hot topics in dentistry, clinical tips, continuing education, and adding value to your life and career. With your host, Jazz Gulati.
Right, Gentlemen, welcome to the Protrusive Dental Podcast. It's great to have you on. I want to make this the most impactful episode about PPE and RPE in the current climate. Let's start with some introductions. Tariq, thanks for reaching out to me. Please tell us about yourself and what makes you qualified, if I say, to talk about PPE and RPE.
So my name is Tariq Shambash. I'm a dentist, oral surgeon, and for the last 8 weeks, I've been redeployed as a fit tester. I've been fit testing qualitatively and quantitatively. I've coordinated a large team of multidisciplinary dental professionals in fit testing, supervising them, educating them. To colleagues, I've been conducting respiratory protection education, as well as raising awareness about respirators and fit testing. Perfect.
How about you, Kareem?
Hi, Jazz. Thank you very much for having me on the show. My name is Kareem El-Bughdadli. I'm a consultant anaesthetist at a London COVID teaching hospital, where we have a large population of COVID patients that have been through our doors in the last 2 months or so. What makes me qualified is that I have not seen a patient that does not have COVID in the last 2 months. I only look after COVID patients at the moment. So therefore, I wear RPE and PPE every day that I'm at work. I'm also the research lead for our directorate. And so I've done a little bit of research on, amongst other things, but on COVID and RPE and PPE. I'm by no means an expert, but I would say that I'm equipped to talk about the RPE and PPE from a day-to-day experience basis as well.
That is fantastic. And I think we're going to learn a lot from your experiences, because what we're about to face as dentists going into the work. And Dr. Sami, please tell us about yourself.
So I'm an oral surgeon. I'm Sami Darwish. I'm an oral surgeon and a periodontist. And I'm not on the front line like these two chaps are, but together we have created an organisation where we have been going around fit testing dentists in preparation for them providing clinical services. So far, it's just been the UDCs, but we're moving into helping the other dental practices open up and ready for service. Like Kareem is the lead researcher in his unit, and I've had a couple of publications out there in the dental literature. So I guess together, the three of us and the huge team that we've managed to put together now of over 40 fit testers, we now created a network of fit testers that's providing the service according to the need. Got ourselves a good system going in getting people ready to go back to dentistry.
Brilliant. Thank you to all three of you for your roles in what you're doing and during this time, whether you're on the front line or you're, like you, Sami, behind the scenes. It's great that you're doing this work. Do you know how many people or how many healthcare professionals have been fit tested by yourselves? Do you have a rough number?
Last count was a few days ago, which was 500 and something.
Yeah, top 560, 570.
Brilliant. And what are the main things that you've learned from doing it? What is it? What I want to know is what's the pass rate of fit testing? So you've done 500 people, but their first time when you test them, and then maybe what percentage pass, and then then you have to try another brand. Give us a flavor of what's going on behind the scenes for some of the dentists who have no idea, who haven't been to these centers to be fit tested. What actually goes on?
Let me start by saying, what's a fit test? A fit test is just a confirmation or an assessment of the performance of that respirator on somebody's face. Essentially, is it compatible with that person's facial features, and in particularly the lower mid-faced. Now, we are dentists. Our team is multidisciplinary dental professionals. We measure the face. We use some 3D scanning as well. And with that techniques, we've managed to find out with our experience and as we go along, what is the most suitable or what's the most likely to be the most suitable RPE, but also constrained with what's available. So to answer your question, what's the pass rate? It depends on what variety of RPE we have and what the demographic that we're faced with. So in a session where it's mainly petite women, then probably the pass rate will be low as 30%. Where we have mainly a male demographic and we have a variety of respirators, then we would have as high as 80 to 100%. So it changes from session to session. Overall, I'd probably say around 70% mark.
70% is a pass rate, yeah?
Yes.
Overall,
overall, 70% pass. But Tarek, do you want to just elaborate slightly on why the petite female group are more likely to not pass?
Because that petite female group is a large percentage of our current healthcare professionals, my wife included, who failed her fit test.
So there are many reasons, Jazz. First of all, respirators are traditionally, the respirators essentially that we're using are industrial products. And we know in industry, it's mainly men larger sizes. That's number one. Number two, we are in a pandemic where there's shortage of PPE, shortage of variety of RPEs. Ideally, a fit tester should arrive somewhere with a variety of RPEs, different sizes, different shapes, and then they see the most suitable. The same as somebody where if you were buying a pair of jeans, you would go to somewhere, they will have all the different sizes, they will have all the different styles, and based on your shape, your size, what you were wanting to do with it, you may go with a stretchy one, you may go with a different color one, and you end up with the best pair of pants that you want to do for that job that you're doing.
The supply is limited. The variety is probably limited during this time. Kareem, you raise your hand, please. What have your experiences been?
Effectively, really, the problem with RPE is, as Tarek highlighted, they're all designed for white men. And so if you're not a white man, your chances of passing a fit test are diminished. The studies have shown that up to across all backgrounds, around a fifth of people do not pass the fit test. Now, of course, the demographics in the UK and the demographics in dental practices may be slightly different to the general population demographics, of course. And so the chances of you not successfully passing a fit test might be affected by that as well.
So then logically, the next thing I want to check then is this significant percentage of the population who maybe due to the lack of variety available at the moment and their facial features will not pass these fit tests. What are we going to do? Let's say the government said or the powers that be that say that we can go back to work on the 4th of July, just made up a random date. What are we going to do?
We need to, that's the whole point of fit testing. What we aim to do as fit testers is seek a answer to what the effect of the mask that the dentist is holding is that functional or not. But what we aim to do is also test them on a variety. So if they fail on one mask, then there'll be other masks to test them on.
Hopefully.
So hopefully. But as the chaps just said, is that traditionally this mask has been designed for the fireman and the construction worker. And one may hope that the industry might change to make masks for the medical and the dental profession, and I'd expect exactly that to happen. But notwithstanding that, there will still be masks that dentists will fit. So if the first one that they're holding ends up being the one that doesn't fit them, then we can access alternatives for them, test them on it, and one would hope in the second, third, or fourth attempt of a different mask, we find one that does fit them. And once we do, then that's the one that we tell them, this is the one that fits you. So that's the one that they need to go and look for and buy.
The reason why there is fit testing now is because mainly we are dealing with what's available to us, and we are in the middle of a peak of a pandemic. Yeah. So we don't know what will be normal routine dentistry, and we may not need respiratory protection. That's the first thing. Yeah. And I hope that we don't, because it's not the most practical. And to be honest, I used to love how I used to practice dentistry. And at the moment, I don't love it as much. But at certain aspects of it, I'm falling in love, the slowness of it, the flow of it. But I'm not a big fan of having something bulky in front of my face. And for my patient, last week, a 10-year-old child having to see me with that respirator on. That's number one. Number two, we don't know. There's a lack of evidence, or there's no evidence on aerosols and risk of transmission. So we don't know. So there may be the fact that we'll get more evidence. There's maybe we will get different respirators that will come onto the market, and maybe we don't need them. Also, don't forget that we were taught in respirator terms, or in respiratory protection, there are two classes of respirators. There are close-fitting respirators, and there are loose-fitting respirators. Loose-fitting respirators don't need to be fit tested, and they are adequate and suitable for any shape, any size. Again, they're not the most, they're designed mainly for industrial applications. But now,
can you name some examples?
So there's the one that has been developed in Southampton University, I believe, and it's Perso, which is an open system, which can be perhaps adapted and perhaps developed further. There's also Max Air, which I believe Kareem has some experience with, and perhaps Kareem can tell us more about it.
I've got some experience with the Max Air, and these are effectively powered air purifying respirators. So these the PAPRs, powered air purifying respirators, are effectively a hood that you will have seen people wearing before. And what they have is they've got a pump, and that pump effectively produces positive pressure within your compartment where you're breathing within your head, and that positive pressure effectively forces air out. Of course, the pump and the fan has a filter on it. Okay, so it's a highly efficient filter usually, and you don't have any tight fitting mask on your face. But you're effectively within this hood. There's various types of powered air purifying respirators, of course, and Tarek has named a couple, and they've got different designs. Some of them have the pump that sits on top of your head. Some of them have a tube, and the pump sits on your hip, disconnected. But the principle remains the same: is you're in a positive pressure chamber. Your head is in a positive pressure chamber that has a filter to prevent viral particles entering.
What's it like walking around with it?
Which one? The PAPRs?
Yeah.
So it really depends on the PAPR, right? Like some of them are really, really super industrial, super bulky, and have space inside. Of course, what you notice is that sound is a little bit more muffled. Communication is more difficult. You can't get close to things because you've got this distance between you and the respirator itself. So it can be challenging. To be honest with you, there's the ones that have the pump that sit on top of the head. They have advantages because they use a disposable visor. Okay, so the hood itself is disposable, but the pump is not, and the pump sits inside that disposable hood, and you do have a buzz that's sat on top of your head, a little bit of a hum that's constantly there, but you get used to it after a while. Listen, end of the day, nothing is as comfortable as having nothing on your face or your head, right? You ideally don't want to wear a mask. You ideally don't want to wear a hood. But you've got to protect yourselves, and if you can't fit a mask, then you've got to try a hood.
Well, so I'm glad you've answered that. So if the mask is no good and we've tried a few, then maybe the next step will be a hood. But until I guess we know what the standard operating procedures will be, that we really don't know which direction this is all going to head in. So I really respect that. None of us know the answer to that. But one thing we do know is that Irish guidance was released and they're advocating FFP2. Now, does FFP2 need to be fit tested? And I also want to know, what if the ability for the fit testers, and I believe there's a limited number of fit testing kits as well. So these are many bottlenecks in the system that may prevent everyone getting access to fit testing, and then maybe will further delay who can get to work. So please, can you talk about that?
So if I can take your first question, first of all, when we do our teaching, we the first principle is a surgical mask is a surgical mask. It's a barrier protection that offers some filtration, which is not standardized. Whereas a respirator is a filtering device that also offers some protection, but most of the time that's not fluid resistant. So FFP2 is FFP stands for a filtering facepiece. Yeah. With a P1 capability, P2 capability, P3 capability. So essentially an FFP2 is a filtering device. Yeah. And any filtering device, any respirator requires a seal for it to optimally perform. Yeah. Because it's a respirator. You want it to filter. You don't want air to escape in from the sides. You want it to have a seal. The only standardized way and recognized way to test that seal on a person's face is through a fit test, which could be qualitative or quantitative. So if an employer or a wearer wants to know the performance of that filtering facepiece, regardless of its being FFP1, FFP2, FFP3, they do a fit test. If they pass a fit test, that tells them that there is a fit factor of at least 100, which means that if there is 100 aerosols outside, there is less, one aerosol will get one particle. If there is 100 particles outside, one particle will get in. And that's what we call a fit factor of 100.
Can I just say at that point that even though you get a positive fit test and you're happy with a brand, and then the fit testers say goodbye and everyone continues, if you just on one day change the position slightly, you don't put it on properly, then that may again be ineffective, right?
Yes.
Part of the program and part of the product that we do is people are saying to us, "Oh, come and fit test us." We can come and do the fit testing, but that's not half of it. We need to train you on how to wear it and how to don it and how to doff it, how to put it on safely and how to take it off safely, and how to take care of it with the reusable ones, how to inspect it, how to clean it. So you're quite right. If the wearer hasn't had adequate training in how to use it, it could be ineffective.
I think what's one way that I like to compare it to is driving, right? So getting your fit test done and passing the fit test for a certain mask is like getting a license for that vehicle, okay, for that type of vehicle. It means that you can drive that car. Say you get an automatic license, it means you can drive an automatic car. Great, but having that license doesn't mean that you know how to drive, and it doesn't mean that you're going to be driving safely. You still have to adhere to the principles of safe driving. So if you get that license, that's the same as passing your fit test. But if you drive with your window, with your door open, with no seatbelt, above the speed limit, then the driving license is effectively meaningless. It's a package, right? It's about training and implementing safe practice, which includes, part of that safe practice includes getting that license or passing that fit test.
So Kareem, I think that's a really important message that you just said, because I'm getting the impression that that people just want to be fit testers and say, "Oh, can you come over, measure me up, tell me which mask I can wear, so I can I can book a patient in next week," and it's actually so not like that. What's just as important as you selecting a mask to fit your face is actually you knowing how to use it. And so I would want to express to colleagues to take with severe caution any form of fit testing that they may be looking for, which is just a matter of come and measure me up and sort me out. It's just so not like that.
Mm-hmm. So thank you so much, gentlemen. The question I have for you now is, until the standard operating procedures are released for England and certainly UK, obviously Irish guidelines have been released, your advice is for example, I'm a private dentist. Should I be rushing out to get fit tested? Is there any reason I should be now, or should I try and get ahead of the curve? What's your current advice to dentists in my situation?
Can I answer that from the ethics point of view? So, although we are providing fit testing and we are responsive to people's requests, I think there is an ethical angle to this, in that PPE is limited, as you're seeing in the media, and I would think it'll be particularly unethical if dentists who are currently shut down in effect by the CDO are getting fit tested and stocking up their respirators to sit in a cupboard inside a closed dental practice. But saying that, I'm also aware that we need to get ourselves prepared. So I think when it looks imminent that we are going to be opening up, then gradually we as a profession and as a team should be preparing ourselves. But I would hate to take away from the front line who are,
of course, that's a very valid point,
genuinely in need.
Mm-hmm.
On a technical point, most PPE that I see, or RPEs that I see available on the marketplace, or when we go to a UDC, we're asked to. So at the moment, we have official supply that has been procured through NHS England and Public Health England. At the end of the session, once we've empowered them with all the information, there is some supply that came not from that official supply, and they don't perform in the same way. So most of what's available now in the marketplace, especially KN95, other not CE marked, there is fake respirators, there are E-loop designs. The ones that are not basically used on the front line, they don't perform as well. So fit testing should be done on a RPE that you know that is likely to fit you. It's on an RPE that it's likely that you will get more of it in the future. And an RPE that you're not taking it away from an operational site because there is shortage of supply. We're likely to be in phased return to dentistry. I don't think it's going to be chaotic return to dentistry. Mm-hmm. There are so many other ways that we know that we can prepare ourselves. I wouldn't, though, ignore the topic and not engage. I would engage with a fit testing team. I would engage and raise awareness on respiratory protection as a whole, because knowledge, it's never, you can never waste getting more knowledge. But buying unofficial PPE from unofficial sources and buying it in bulk without engaging a fit testing team, I think is definitely the wrong approach. Having a sample of some RPEs that are likely to be available later on, and engaging a fit testing team that will empower you with knowledge and how to do it properly, I think is the right way forward, personally. And that might change next week if the guidance change, if the supply chain changes, if what we're being asked to do is different. From our experience, returning to work should be a coordinated, professional step. Should be done on an individual basis. There are communities of practice. You have a network of colleagues around you, and doing it as part of a coordinated approach with your local professional network, I think is the right way forward. no matter what that step is, and no matter what the preparation is. I think if this time taught us anything, we need to come closer as a profession. We need to come closer as different professions and different workforce and help each other out in a time of need. But also we should carry it on and use expertise in different sectors and help each other out.
Brilliant. So, gents, the next question I have is sent in by one of the listeners who I encourage to send in any questions we have for the group today. And I'm going to borrow your knowledge here. Is with the antibody test being more widely available now, and certainly I've been looking online. I'm very keen to get one ASAP, so that hopefully I won't have to wear a hood. Is my thinking now. Can I go back like how it used to be? Can I go commando if I'm antibody positive?
Yeah, I mean, firstly, I don't like the idea of going commando ever anyways. But there's 2 points here. I think firstly is you've got to make sure that the kit that you're using to test yourself is validated, right? Because there's lots of kits that are out there that you can buy. But one of the reasons why it's taken so long for the government to approve something is because the validation processes are quite rigorous. And if you're using something that's not validated, then you may get a result which either will be falsely reassuring or falsely concerning that may not be accurate. So that's the first thing. So the second point is we're still learning so much about this disease right now. Okay, so having antibodies to SARS-CoV-2 doesn't. Firstly, you can have asymptomatic seroconverters. Okay, so there's a large population of people. In fact, some studies have now suggested up to 44% of healthcare workers are asymptomatic seroconverters, which means that you've got the antibodies without having declared any symptoms. But having the antibody does not necessarily mean you will have lifelong immunity. We do not know how long the antibodies will last. We do not know how the virus will adapt and change. So at the moment, I don't think that it's a wise idea for us to say, I'm all good, I've had it, I'm immune, it's done. We still don't know. And I work very, very closely with our virology and infectious diseases department. And we've done several studies and we're working on lots of studies on it at the moment. And certainly directly from them, they categorically say you cannot assume that if you've got the antibodies that you are going to be in the clear. I'll give you an example. We intubate patients with COVID all the time, and about a tenth of clinicians who are involved in tracheal intubation have gotten COVID. Okay, I have several colleagues who have had COVID, swab confirmed COVID, and despite that, when they return to work, they're wearing full RPE and PPE. So I think that it would be playing with fire if you think that having the antibodies on a test means that you're immune forever, because we really don't know enough yet.
Okay, fine. I think that's answered it categorically that no, you shouldn't go commando. So if you're antibody positive, until the research is out there to suggest otherwise, that we should still go with whatever the SOPs will be once they come out. Is that a fair summary?
Yeah, and we need to be guided by the evidence, and the evidence is still, it's way too early for us to draw any definitive conclusions on anything and to take any risks. So until we have definitive evidence, let's play safe and let's do the right thing.
As talking as someone with a beard, I'm sure obviously you know the issues. Well, you've been subjected to many people you've tested, or you've probably declined to test. If someone's got a beard, you're probably not going to test them. You're going to have that conversation about shaving. Now, putting religion even aside, because I know I'm a Sikh at the end of the day, but my listeners are not all Sikh. So let's talk about the hoods, because that is one way to get around a beard, or the fact that, let's imagine any type of mask, facial mask does not fit you, for example, then therefore we're now looking at a hood. But for those people who have tested some hoods, and I've got some colleagues who are testing some hoods, they find it that the type of, and Dr. Sami, being a periodontist, the type of fine work that we used to do, perioplastic work, resin work, things that need good vision and clarity may not be as easy to do, and it's very cumbersome, like we said about the weight as well. The fact that you may have to use a saddle chair, and a normal chair with a backrest will not be, you won't be able to use that. So there's lots of issues. So I'm personally really looking for any solution that will not involve a hood. So I didn't really finish with a question there, but what I mean to say is, hopefully we're not going to need to all use hoods, but what advice can you give to those who may need to use a hood, and how to do good quality dentistry? Is that even possible?
So I think we're going to have to readapt in many respects. And I think the clinical environment itself needs to be adjusted for the new era that we are now in. I agree with you. For those that are wearing a beard, if the respirators are, well, the respirators clearly are not an option for them. So it has to be the hood. So then you can work backwards from how are you going to adjust the surroundings to the hood, much more space around the dental chair. I think, you see, I when I'm operating as an oral surgeon, I stand up. When I'm operating as a periodontist, I sit down. You make a very good point about the chair. I mean, the chair with the back on it may be something that you might not be able to use anymore. So you think about using the saddle or standing up. As was mentioned earlier, that hood is there's an element of distance created, and that distance is a physical distance, and it's also a psychological distance. We can't communicate with our patients as well. That badly affects the element of empathy that we can provide to our patients as we give them a more holistic chairside manner to our approach. These are all things that we're going to have to change. The loops is an issue at the moment, and I know there's the leading suppliers in microscopes and loops are looking at ways to adapt into the new need.
Because even the scopes are difficult, sorry to interject, but even the microscope, my colleagues who are testing all this sort of stuff, hoods, mostly, we've got a group of Sikh people with beards and turbans who are trying to preempt a solution that will allow us to do good dentistry, but also be protected. And they've confirmed that loops are difficult, and microscopes are also finding difficult. Yes, Kareem, this is Tariq, sorry.
Jazz, we are testing now and working now with industrial products that are designed for industrial applications and trying to adapt them to the healthcare workplace. The marketplace is dictated by demand and need. So already we are, as a group, working with a couple of respirator manufacturers to evolve and develop some solutions. And that's been driven by the demand. So if it is going to be, as you say, our likely SOP, and it's going to be needed within the healthcare industry, rest assured there will be developments by dentists, for dentists, by healthcare providers, for healthcare providers. We are innovators. We have a lot of creativity within our professional industry, and rest assured that there will be some new designs that everyone will be protected, if need be, through a respiratory respirator. They will have the right solution for them, and most likely it will be developed by a dentist. Mm-hmm. Or at least the development will be, there is contribution by a dental professional within that, or a healthcare professional at least.
Fine, but it's just a lot of concerned people thinking about, we know that dentistry will never be the same again, but even to do the types of procedures we used to do for some period of time, we don't know how long, but for some period of time, we may be limited to doing extractions and very basic stuff. What I'm trying to say is that the techniques and the treatments that involve finesse may be difficult to do so early on until, as you say, Tariq, the market responds and comes up with some RPE equipment that makes it conducive to excellent dentistry.
But we also adapt in our techniques, though, don't we, Jazz? I mean, as time has gone on in dentistry, even equipment has changed, and we end up trying out new things, learning new techniques, and I think we'll be forced, if you like, to do that in this era as well. We have to come together and accept that what we've always been doing all along has to be ready to be readapted. It's very difficult for a golfer to change a swing, but we are going to have to learn new techniques. And you're quite right to mention a particular group. We see the Sikhs and Muslims and Jews have a problem with the beards, but previously we've had concerns where women wearing hijab and long sleeves haven't been able to scrub up in theatres. Some innovative response to this of thinking outside the box to accommodate their own wishes, but also an element of just being a little bit more fluid to the approach, of saying, maybe I will have to just change the way I stand. Maybe I will have to change the way I look into the patient's mouth. Maybe there will be different lighting systems. We have to think about this together.
We're living in an era, in an era where digital scanning and custom-made devices are more readily available. So creating a seal around the face, there may be other ways of achieving it. And all you need is for a close fitting. So there are two developments that need to happen. Ways of achieving a seal around the face and working around the restrictions of a person to make it personalizable. And maybe a loose fitting solution where it is more, it's conducive for the fine work and what we need as healthcare providers.
Thank you. I've been speaking to some people who've been trained to do fit testing up north in the York region, and they're covering a huge area. I mean, they're covering from, let's say, Yorkshire, Sheffield, all the way up to Newcastle, and they're driving in between these areas. So with the lack of, let's say, fit testers to fit test, let's say, minimum 60,000 people, that's like 30,000 odd dentists, and there's far more than 30,000 nurses. Let's assume a conservative figure of 60,000 looking to come back to work. I appreciate that you think there'll be a phased return to work, but certainly I think there'll be some bottlenecks in being able to get fit tested. And let's say one brand of mask runs out and then suddenly you need to get fit tested again for another brand. So there's lots of issues, and I don't want to get too much into the intricacies of all this, but people will try and get around it and get to work as fast as possible. So all this preamble is basically one of my listeners who really wants to crack on as we all do as quickly as possible, asked, is it possible to or advisable to wear a FFP2 that you may not have had an opportunity to get fit tested, because they're thinking pragmatically that it might be difficult to. And then on top of that, wear a face shield. Do you think that will give an adequate level of protection, is the question from the listener.
Well, I mean, it depends. It depends what the personal definition of adequate is. I think we are all in it together that we want to minimise risk. Of course, one bit of protection is more or less compared to another bit of protection. Our job here, or where we see our role, is to help educate the individual to make their own risk assessments. Indeed, there have been those that advocate not fit testing in FFP2. I've seen it, and I think it's a personal choice. I mean, if somebody wants to know if whatever they're wearing on their face, be it a kitchen towel, is it allowing some virus to go down the side? If you want to know the answer, then you need a fit test. I accept that maybe we might be taking more risks to start with because of the bottleneck. But the mindset to think that let's relax our safety measures is something that I wouldn't advocate.
Thank you. And Kareem, I believe you, with your vast experience of being on the end of wearing all these PPEs, RPEs, is there anything that you'd like to add to that?
Yeah. Firstly, I just want to give just a slightly different perspective on FFP2 and FFP3, where people are thinking that FFP2 means you can be a little bit more loose with applying it. What people need to bear in mind is that in North America, for example, they don't use FFP3s. Okay, so the standard there is FFP2 or N95. That's their standard. So forget thinking that FFP2 is different to FFP3. It's just about the viral filtration efficiency. That's all. That's the only difference. It still needs to be fixed. On to use the respirator to protect yourself from a potential viral exposure, it must be fit tested. If you want to take some potential risks, as we talked about already, okay, so at least a fifth in published studies and a third in our data from the people that we fit tested, between 20 to 30% of people, they do not have an adequate protection if they have not been fit tested. Okay, so it's up to you to decide if you're prepared to take that risk. I know I probably wouldn't be prepared to take that risk. Okay, but if you're prepared to take that risk of not being protected from exposure potentially from a patient with COVID, or I should say at least carrying a SARS-CoV-2, then that's up to you. But I would be guided by the evidence and by the data, and the evidence currently suggests that's not a wise idea.
Okay,
Can I take a third perspective, if that's okay?
Yeah, please.
So,
this is what it's about.
Let's understand the principles, right? You don't have to wear a respiratory. It's not illegal to practice without respiratory protection. It's not illegal not to do a fit test. A fit test is a method to show you what seal you have from the respirator if you've made a choice to use one. If you use a respirator, you probably are more protected than using just a surgical mask if there is aerosol with particles, if that particles carries a viable virus. We don't know the risks. We don't know what's in those particles. And we don't know what's the consequences of being fit tested or not. All the principles is if you're choosing to use a respirator, which means you're choosing to protect yourself from the particles around you. If you want to do that to the optimum way, a fit test is the way to demonstrate it.
The next question I have is, I've heard reports that in the urgent dental care centers, that because of the lack of PPE in some centers, the dentists are being encouraged to wear one FFP3 mask or whatever they're using per session. So a morning and an afternoon, and then between patients changing the surgical mask that will go over the FFP3. That may be a pragmatic and practical solution at the moment. Is that something that you think can work for practices that may want to be saving money in the future? Because if that's the current standard of play, can we not continue it like that? Is there anything bad about doing that?
If I can highlight a few issues, we're in unprecedented times, and we're dealing with a large problem of not having the constant supply, and we're having to deal with that and care for our patients that need urgent care. So they need urgent care. We're on a high peak pandemic with no limited supply at the moment. The Public Health England, and maybe that's I may be incorrect, but my interpretation is a respirator should be used in a for single use in primary care settings. In secondary care settings, if there is a shortage, then it may be, and it's an appropriate setting, then it may be used as a sessional use. I haven't seen any official document to say that you can use a surgical mask on top from a Public Health England point of view. Yeah. It is thinking outside the box, and it is extending the use of it. And I believe the latest guidance from BAMS, the British Association of Oral Maxillofacial Surgery, advocates that. The problem that we have is the FFP3s currently in supply are not fluid resistant, and we don't have many of them. So adding a surgical mask on top offers you that extension. But we also use a face shield on top, which offers some protection. Respirators should not be modified in any way, because the whole point of having a fit test and checking with the respirator is that you wear it correctly, consistently every time, like you said earlier, right? So if putting a surgical mask, does that affect the fit or not? I don't know. Does it increase the chance of you, when you're removing the surgical mask, for it to dislodge the respirator and break the seal? I don't know. Does it offer any protection for fluid on top of having a face shield on top? I don't know. Does it offer some filtration for the FFP3 mask that have an exit valve, and potentially the wearer may be an asymptomatic carrier and working with a vulnerable patient or a shielded person and coughs during? Does that surgical mask offer some filtration or not? I don't know. The ideal gold standard going forward would be to have a disposable FFP3 that is fluid resistant, that has that is not valved, and that is cheap and widely available on the same model that you can get every day with adjustable straps that comes in different sizes. Then we would have solved the problem in dentistry and healthcare, and manufactured in the UK.
Per patient.
And yes, and manufactured in the UK, and conforms to the quality standards of the British standards of 149 or whatever standard. So if we have a UK-made solution that passes the test, that is cheap for us to use per patient, per procedure, that's easy for us to wear, comfortable for us to wear, that we can adjust the straps, that comes in small, medium, and large, that is fluid resistant, then I would buy that and wear that. And probably I'll be, whether I need it or not, I'd probably now choose to wear it if it is readily available and economically makes sense to me.
Should we be switching to reusable PPE? So some of a mask that looks like one of the Bain ones, I believe that's what they tend to look like. Is that something that we should be thinking about instead of having to constantly worry about supply demands and whatnot? Kareem, I believe you may be well positioned to talk about that.
Yeah, I mean, listen, there's obvious advantages. There's obvious disadvantages as well, but there's obvious advantages to having a reusable. One, actually, in the long run, it's more cost effective. So if you're thinking of one of the reusables, it costs anywhere between £30 and £50 without having to replace a filter, of course, because there's an additional cost of having to replace a filter intermittently. And if you compare that cost to a single disposable FFP3 mask that we commonly use in the NHS, they're in the range of £5 to £7.
Wow.
So immediately you can see that there is a cost benefit there. Okay, so there's a cost benefit. Number two, because it's reusable, you do not risk running out of supplies and needing to be fit tested in the next type of RPE that your employer provides you. Okay, so you've got it, you fit test on it, you know it works, you use it thereafter. Okay, and number three, you can keep it for one individual, or it can be shared amongst individuals if it's clean. So for us, certainly with what I do, we have reusable RPEs that I keep my own one. I have my own one that I've been fit tested on, that I look after, that I care for, that I check the filter on regularly. I'm not worried that I'm going to run out of supplies. I'm not worried that I'm going to need to be refit tested again. So there's obvious benefits to them. There's some drawbacks, of course. The drawbacks are they're bulky, they're large, they need to be cleaned. And of course, you must remember that the whole process of doffing these is a much more challenging process than doffing a disposable, because a disposable, you carefully take it off your face with your eyes closed and drop it into the bin. But with these, you've got to be very, very careful, because you're not dropping it into the bin. You're going to be grabbing it. There's 2 straps that need to be pulled out. You're going to be grabbing it, and then you need to be cleaning it. The cleaning process itself poses potential theoretical risks. There's no data to support this, but it's all theoretical risks that you may be dispersing any virus that's on the RPE itself. So you've got to clean it. And what we do is we clean ours. I clean mine myself, just because for my own peace of mind, once a day, by disassembling it and cleaning it properly as per manufacturer instructions. Different manufacturers have different instructions, and you've really got to adhere to those instructions. So there's pros and cons of using a reusable versus single use. To my mind, having the benefits of having the reusable, for me personally at least, outweigh the risks and the drawbacks of the bulkiness and the cleaning.
Sami and Tariq, as dentists, do you think reusable is the way forward?
Well, I think that all that Kareem just elaborated on is equally applicable to us. The one thing I would add about the bulkiness is this thing is like stuck to your face, and dentists in particular, we're working a good, 6, 7, 8 hour day at least with this thing stuck to our face. I don't know how many patients we're going to be seeing in the post-COVID era compared to how many patients we used to schedule in our diaries before. But that in itself is going to be a challenge, and there'll undoubtedly be, facial marks on your face after you've worn it. That could possibly cause scarring. I don't know. It's something that we're going to have to consider when we're selecting which type of protection that we're going to use, and in dentistry also, certainly, for oral surgery, for example, I can sometimes see patients every 20 minutes, for goodness sake, but I don't think I'm going to do that again. But incorporating in that schedule now is the donning and doffing and the inspection and the cleaning. So it's so many factors now to put into the melting pot that we previously didn't consider.
I have access to both, and I'm fortunate to have access to both. Certain procedures, I would wear the reusable respirator. Certain scenarios, I will use the disposable. For example, yesterday I had an anxious lady that needed an impacted third molar removed, so it's likely to be an AGP. And I chose to put the disposable one because I didn't want to add another fear factor. Is probably the way forward. And as a fit tester, a variety of sizes for a variety of scenarios is probably the way forward. Both, all close-fitting respirators are designed for a short period of time, and the health safety executive expects a wearer to wear it comfortably for less than an hour. So after an hour, you'll probably more likely touch it, you're more likely adjust it. So they're not designed for extended use, both of them. And as part of our fit testing, the first thing we check, can you put it correctly, consistently yourself? Yes. Can you comfortably wear it and work with it? Yes. And then we do the fit test. And we've had people that put on a disposable and think, no, this is too much for me. We've had people that stay on the whole training session with one. We've had people try on the reusable and say, yeah, that's fine. I don't see any problem with this. I actually do this when I do my DIY work at home, and I'm used to it. And some people put it on and say, no, I'm never going to wear this. I hate the look of this. That's not for me. And we have to be prepared for that. A respirator is a way of controlling the hazard. There are other ways of controlling the hazard. There is, dare I say, not doing AGPs, dare I say, controlling the hazard in another way. And don't forget that a respirator is the last resort in the puzzle. So all other things that we do is the right thing to do. Respirator should be considered as the last resort in protection and controlling the hazards.
Sami, with your ethics background, I want to ask you, who should be paying for this? Private practice, who should pay for, let's say, all these FFP3s? Because I'm increasingly seeing some principals trying to plan the future charge of this to make the associates buy their own PPE. Where do you see this?
I mean, I might have a law and ethics education, but that's certainly far be it for me to give an opinion on how people should be running their own businesses. But I'm a principal as well, so I understand the issues here. I mean, it's a minefield. I think the law states that employers need to be providing a safe working environment for their employees. And sadly, in this new era, that means providing them safe air to breathe. Now, that's a really, really sobering thought. But then equally, principals haven't traditionally provided loops for dentists. They haven't. Some provide them with their uniforms, some don't. It's something that's going to have to be an internal decision.
I just thought I'd ask your opinion.
I haven't even answered that question for myself and my own staff yet. It's going to be a really tough one.
No matter who pays for it, we need to make sure that we're protected and we have the right equipment. That is, if it is a respirator, then ideally should be fit tested, and we need to. And then if the dentist pays for it, then does the nurse pay for it? And if they pay for it themselves, do you quality assure it? Do you make sure that it's working? Do you make sure that it's fit tested? So quality is, I think, what's important. Paying for it and who pays for it is obviously an important question as well. But for me, the quality and the safety of everyone involved. And I'm sure we will have a professional guidance on this from the people that are expert in this.
Okay, fine. So gentlemen, the final question I have is, with us potentially, fingers crossed, hopefully getting back to work and the inevitable increased demand for fit testers, because based on what you're saying, it sounds like for your safety, for the safety of our staff, it's really important because we don't know exactly what we're dealing with just yet. We need more research. So for the time being, I think what I'm sensing is that it's something that we should be getting done proactively once the decision is made about SOPs. So should there be more people getting trained for fit testing? What does it involve? And just give us a flavor about that.
So I think, yes, knowledge is key. If we need fit testers, we need professional fit testers, not industry fit testers. Training and becoming a fit tester, there are two methods, qualitative or quantitative. It is both it's a skill, it's an art, and it's a science. So with that, any skill, art, and science need you can't just grab it by reading a book. You can't grab it by just watching a video. You need to be trained, educated. You need to practice that skill. You need to have it observed. You need to reflect on your performance and be supervised to gain that competency in a safe manner. And that's what we've been doing thus far. Not just training, but reflecting, supervising, mentoring, and ensuring that the competency is gained safely. Whoever provides the fit testing, it's a legal requirement for them to be competent in doing so. Sure. There is a British safety, there is a accreditation scheme, and being accredited as a fit tester is the gold standard of fit testing. But that's for industry. In healthcare, we need well-trained professionals that are able to do it within our context, understand our environment, understand what is needed. And I think we are, as dental professionals, not just dentists, but all of the dental professionals are ideally suited to be our own fit testers if we need it in the future.
Brilliant. Sammy, did you want to add?
I just want to agree with that so much in that, in the time gone by, firemen and construction workers have had to receive an element of training and a level of fit testing that's appropriate to their environment. And the world in healthcare has just changed overnight now. So whilst a great majority of what they have overlaps into our environment, there's a substantial amount that doesn't, and therefore is missed by generic training. I think targeted and focused training that is relevant specifically to our profession, and we've just talked about some, haven't we? We've talked about sitting in the chair or a saddle. We've talked about the loops. We've talked about the empathy of chairside communication with the patient when you're appearing differently than when you did in the last appointment with them 6 months ago. These are all things that the construction workers haven't needed to address in their field of work. So our model has brought all that into one basket in order to make it more focused and relevant.
Sure. Kareem, anything you'd like to add?
Can I add? I wanted to add something, Jazz, if I may. There are some personality traits that suit, or qualities of a person suited to become a fit tester. You need to be pay attention to detail. You need to be conscientious. You need to give confidence to the person that you're fit testing. And you need to not just want to tick the box. I have attended about 6 training courses, all of them accredited, and I've had different experiences. We all know training can be different and can be the same content can be given by different people, but the result can be different. Also, we know that 6 people can attend a course and their competency after the course can be different. So not everybody that is trained to attend a course to become a fit tester is a good fit tester at the end of it. You need to have a process to ensure that the person at the end of that training journey is competent.
So what's the difference between a fit test and a fit check?
So a fit test is, as we discussed earlier, an employer's responsibility, and it's a way of assessing the performance of a respirator and whether it's does it conform or create a seal with that person's facial features. It lasts for 2 years, and it's only for that particular model of respirator. And it's not valid if the person loses weight or gain weight or anything that affects the seal area, including significant dental work, then makes it invalid. A fit check is the responsibility of the wearer, and that's something that they should do every time they don the respirator. And it gives them confidence that they've done it correctly, consistently, and they're trained to do it. For each type of respirator, it's a different technique.
So everyone who gets fit tested and starts wearing an FFP2 and FFP3, for example, everyone needs to be a fit checker, a proficient fit checker.
Yes. For that model of...
Part of the training, part of your fit testing is to be trained to fit check. So that's one of the reasons why fit testing is so important, because it teaches you to fit check. There are some people that think that I can fit check without having fit testing. So a fit check is effectively you put the mask on, you suck in, and if it sucks in effectively, and if it feels like there's a seal, then you should have confidence in that. But that's to my mind, that's probably insufficient. Because you need to have quantitative, not just qualitative, but quantitative and objective measures to demonstrate that you have an effective seal. Whereas fit checking is purely subjective, and it carries significant user error.
So we're setting the standards I hope, in dentistry, that fit testing should be the required risk management strategy. But is that the case in hospitals, Kareem?
Well, I think that there's been some institutions across the UK who have effectively said that you should that fit checking is sufficient, and that probably comes down to the fact that there's probably too many clinicians or healthcare workers that need fit testing, but they do not have the capacity to fit test everyone. And so therefore they've made pragmatic decisions to meet healthcare demand that people should just fit check. And I think that if you're taking responsibility for your own health and well-being, then I don't think personally that would suffice. And I would encourage employers to really consider doing what's best for their employees as well.
We're quite fortunate, I think, in primary care dentistry that we do have much more of a level of autonomy to make our own decisions in this regard. So it's not going to be we're victims of a departmental policy of a large organisation. I mean, dental practices can make their own risk analysis in this regard.
Brilliant. And can I get some rough dates? Sammy, when do you think I'll be able to do some composites again?
Well, the last time I did a composite was about 25 years ago. And I certainly hope I'm not going to be doing one anytime soon. But let's be positive about this. I know there's lots of politics involved, and I know there's questions as to which advice we should be following. As Tarek has alluded to, I think it's going to be a phased re-entry back into the profession, and I think we'll probably be doing more of non-AGB procedures to start with. I'm not gonna put a label on anything. I would hope that we're practicing dentistry in July.
Can I add? First of all, when it is safe for you, when it is safe for the nurse, when it is safe for the patient, when it's safe for other patients in the practice to do so. Or also perhaps when we have the evidence that it is safe for you, for the nurse, for the patient, for other patients in the workplace, for you to do so. Also, I hope, last message is for us to go back to work. We need confidence from the profession. We need guidance from the profession. We need a coordinated approach from the profession. We need the patients to have confidence in us. We need the CQC to have confidence in us and on our workplaces. We need our workforce to be confident in their ability to do everything safely, that they are protected, then that their patients are protected, and that their loved ones at home are protected. I had resistance from my loved ones saying, no, don't go to work because with all this fear around, I don't want you to bring it home. How would you feel if I felt ill? So I think first of all, we should already be working now. We should be preventing disease. We should be reaching out to our patients. We should be engaging with them. We should be helping the national response and taking the burden out of the 111 triage. I know I spoke to a GDP this morning, and that was taking calls despite his normal hours not being open on a Saturday, just to take that burden off 111. So the as much effort that we all do as a profession, the quicker we will get to normal, whatever what that normal might be.
Well, here's hoping that it will be ASAP. Gentlemen, it's been great to have you on the podcast today. Lots of facts, so much needed because there's lots of speculation going on. Thank you for all the hard work that you guys are doing behind the scenes and, of course, on the front line as well. Really, on behalf of the nation, thank you guys.
Well, you're welcome, Jazz, and thank you very much for having us. It's great for us to get together and chat and to be thought-provoking in this way. We see ourselves as just a very, very small piece of the jigsaw puzzle, and we're happy to help anybody that reaches out to us. I'm happy to put our email address out there, which is info@dakatra.co.uk. So that's spelled info, INFO, at Dakatra, which is DAKATRA.co.uk. Anyone that has any questions, by all means, our doors remain open.
Brilliant. Well, thank you very much, gents.
Thank you for having us.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you.